Our entire goal, our aim is to find that last out-of-school girl who's been excluded from an education. Either she's dropped out or has never been enrolled. And our mission is to find her, to bring her back into school, make sure that she's staying and learning and thriving.
We realized that Educate Girls needed a way to predict which villages had the most out-of-school girls without needing to rely on an expensive or slow door-by-door census.
We have so much data. We've actually knocked on millions of households. What can we do with this? And how do I leverage this for higher impact?
These data sources weren't always very accurate. So we would end up with carpet bombing. We would cover 100% of villages in a program district. And then in these 100% of villages, about 20-30% villages wouldn't have a single out-of-school girl. So we would disproportionately allocate resources in some villages, and then some villages would stay under-resourced.
To accomplish this, we decided to build together a targeting algorithm using common machine learning techniques to try to predict the number of out-of-school girls in each village. This was particularly difficult in this case as we were working with data from over 200,000 villages across northern India. So over several months, we cleaned and we merged all the data, which actually ended up being the most labor-intensive part of the process. And then from there, we spent 3 to 4 weeks building a proof of concept algorithm that allowed us to predict how many out-of-school girls we expected to find in each of those 200,000 villages.
So we were very apprehensive to begin with, because we did not really know how predictive modeling worked. So when IDinsight presented their first version of the model, we really did not know whether we could rely on what the model projected for us. The algorithm has helped us improve our outcomes-based approach.
The results really drastically exceeded my initial predictions and expectations. To give you an idea, when we first started working with Educate Girls, they were finding between 10 and 15 out-of-school girls per village on average over the course of a year. And in our latest round of expansion, they found around 46 out-of-school girls per village, which is a 3x increase. When you think about that applied to the 20,000 villages that Educate Girls have planned to expand to over a 5-year period, this means just from this targeting approach, they will reach around 600,000 extra out-of-school girls for roughly the same budget.
In the first 10 years of my journey, I was able to enroll 340,000 out-of-school girls. At that run rate, to bring back 1.5 million girls would take me 45 years. And this level of insight, what it does is it supercharges the speed and scale of impact that I can now bring 1.5 million girls out of school in 5 years, because I know exactly where they are and I know exactly how to solve this problem. And that's what IDinsight really did for us. It kind of said, you know what you would do in 45 years, let's do it in 5 years.
My recommendation would be, please don't be apprehensive of leveraging data. It has immense power. It gives you a leg up when you are crafting solutions for the ground. It gives you a leg up when you are advocating for improved investment in certain public goods. It gives you a leg up when you are negotiating with your funders. So we, as civil society, perhaps we have never really understood the power of data. As an organization, Educate Girls has benefited immensely from our partnership with IDinsight.
What I find really special about IDinsight is that they are your true partners in chasing impact, in chasing this, not from just an evaluation, policing, research lens, but they are your operational partners.
Good afternoon, everyone. Welcome to Data and Devolution, addressing health issues through evidence-based decision-making at all levels of the Philippine government. We're very excited to see a lot of participants joining us today. I'm Aya Silva. I'll be your host and moderator for today's event. I'm a director at the Southeast Asia office of IDinsight. IDinsight is a mission-driven global advisory, data analytics, and research organization that helps global development leaders maximize their social impact. We tailor a wide range of data and evidence tools to help decision makers design effective programs and rigorously test what works to support communities. In today's webinar, we will explore the crucial role of data and evidence-based decision-making in addressing health issues in the context of an evolved health system in the Philippines. With the Mandanas-Garcia Ruling that you might be familiar with, this grants local governments greater autonomy, and which means at the same time, evidence-based decision-making at the local level becomes even more critical. The ruling grants local governments increased budgetary autonomy and decision-making power to decentralize social service delivery. And so to inform these decisions and improve delivery, local governments require robust data and monitoring and evaluation capacity. It's essential for local governments to have access to accurate and timely data to guide their health policies and interventions. But not all data available is immediately actionable for local governments. In many cases, data is available at the national level and not disaggregated at the local level, which makes it difficult for local governments to understand what's applicable to their constituents. Data must be representative at the local level to be useful for LGUs, but doing so is operationally difficult and costly. So our session today will explore the need for data across all levels of government, the challenges and practical approaches to strike a balance between that demand for local action-oriented data and the need for national level data for policymaking. So we're bringing together experts from different sectors to share their perspectives and explore practical approaches for generating actionable data. Dr. Manuel Dairit will give the opening remarks, and then we'll hear from Dr. Gab Borlongan from DOH, who will give us a national level perspective. Then Dr. Dina Nadera will share her experience as a researcher working with local governments. Then we'll hear from Dr. Olga Vertusio from Parañaque City for a local perspective. After that, Dr. Alice Redfern will share experiences designing research for both national and local use. And then we'll spend some time together on a panel discussion, and we'd like to hear from you, the audience, your questions for our panelists. This event is organized by IDinsight and the Ateneo School for Medicine and Public Health Center for Research and Innovation, and is part of the 2023 gLOCAL Evaluation Week, a unique knowledge sharing event that connects a global community of people across sectors and regions. We will begin with opening remarks from Dr. Manuel Dairit, adjunct professor and former dean of the Ateneo School of Medicine and Public Health. Over to you, Dr. Dairit.
Thank you, Aya, and good afternoon to everyone, and welcome, and thank you for participating in this session. The lack of data and integrated data systems is a massive barrier to improving health services and tracking health outcomes. Very briefly, let me just reflect on three situations. First, the devolution of the Philippine Public Health Services in 1991. After the devolution of the public health system, which was very precipitous in 1991, the flow of data from local government units to national government was inadequate and sometimes non-existent. Many LGUs, angry at the situation, refused to share data. The situation was reversed only after many years. Two, the COVID-19 pandemic. The response to the COVID-19 pandemic turned for the better when data systems were set up to track the number and place of infections and even the available hospital beds. Fixing the data system was done collaboratively by government and the private sector. And there are many lessons we can learn from this experience. Three, the universal healthcare law. The implementation of the law, I dare say, will only be as good as data and the data systems in place. There are several data systems in place, but the data system is still quite patchy and fragmented. And we are implementing the UHC law within a devolved system. How can we improve our data and our data systems? Optimistically speaking, let me just say it's a work in progress. But let me highlight 2 points. One, there are multiple stakeholders. The discussion on improving data, particularly health data, has been ongoing for years. But it does not just involve the DOH. It includes other branches and agencies of government, like the Department of Information and Communications Technology, the Philippine Statistics Authority, NEDA, other national agencies, and of course, the local government units, and not to forget, the private sector. Two, there is now a new law on community-based monitoring system. That's RA number 11315. It mandates the Philippine Statistics Authority to implement this CBMS. And hopefully, it's going to improve the use of data across the country. So what are the specific objectives of this meeting? It's very, very simple, and you can see it there. We can really look at the challenges, the roles of various stakeholders, and innovations on data and data systems. And hopefully at the end of this 2-hour session, we will come away with more ideas of how to move forward in the coming years. Thank you very much.
Thank you very much, Dr. David. With that, let's dive into the presentations. I'm excited to introduce our first presenter, Dr. Gabriel Borlongan. Dr. Borlongan started his career in public health on the front lines as a doctor to the barrio in Masbate, Bicol region. He then went on to work on research studies before going on to work in various key projects within offices in the Department of Health, from the field implementation and coordination team for the UHC integration sites, to the Epidemiology Bureau for adverse events following immunization, and then to the Disease Prevention and Control Bureau for health system strengthening. Currently holding position as Chief of the Policy Planning and Strategy Development Division of the Field Implementation and Coordination Team Technical Office, let's all welcome Dr. Gabriel Borlongan.
Thank you, Ms. Aya. Thank you, Dr. David. Good day to all. First and foremost, my deep gratitude to IDinsight for inviting the Department of Health to share our insights, experience, and the directions of the agency and the health sector as a whole in relation to health governance, particularly how various information generation mechanisms influence health policy and systems. To see how governance in general works in the Philippines, we have to be cognizant of the fact that there are 4 levels at the least. 1 at the national level, 81 provinces in blue, and around 40 highly urbanized and independent component cities in purple. Provinces in turn govern and steer component cities and municipalities, the orange circles, to which there are over 1,600 nationwide, with an average of 28 per province. Each component LGU and also the highly urbanized and independent component cities govern and set the directions of their component barangay local government units, colored white, which are around 42,000 nationwide. While not visualized, Each barangay, as the smallest unit of governance, are the ones within first contact of 100 million individuals and families all around the country, whether it be for direct patient services or population-based health services, specifically for case finding, contact tracing, following up defaulters, those who missed their scheduled follow-up, and even setting the healthy governance within their own localities. Hence, when we say government health services, there are a variety of institutions, offices, and providers. It is the job of the national governments to steer all of them, but also the private healthcare providers, so that we could all promote health, protect Filipinos from risks, and provide care when needed, while strengthening the enabling systems that deliver these essential public health operations. So these four thrusts are what we call the health sector strategy for the 2023 to 2028. So while the DOH is in direct contact with all of the blue, purple, and orange circles through the regional offices, which is very large. Hence, if we want to really deliver improvement at the grassroots while efficiently using our limited resources, there is a need to focus in building force multipliers, generating catalysts through these institutions, while also through the private sector, other national government agencies, and even the academe. Likewise, the direction is now at building greater capacity at the regional and local levels so that we could always provide guidance to our provinces, city, municipal, local government units so that they could work together and improve their province-wide and city-wide health systems, which is the direction of the Universal Healthcare Act. Now, focusing only first to the government side, we follow what is set based on the devolution, which was set as earlier by Dr. Dairit back in 1991, but re-emphasized with the Mandanas-Garcia Ruling. In a nutshell, that there is no new devolution. It's more of an emphasis of functions between the local government units and the national government agencies. So in terms of the LGUs, these functions were redevolved or emphasized, and with the new increase in national tax allotment, there is increase in resources that could translate to delivery of basic health services. Consistent with the local government code, local autonomy will be strengthened, which will enable LGUs to become self-reliant communities. And likewise, all of these are consistent with the Universal Healthcare Act when we want efficiency in resource allocation and utilization and ownership and accountability so that we could prepare for the development of province-wide and city-wide health systems. For the Department of Health, it is re-emphasized that the agency is the leader in health, an enabler and capacity builder from HR to systems, and also as an oversight mother agency to its attached agencies and corporate hospitals and other institutions under its direct supervision. Likewise, the Department of Health takes care of the financing of population-based health services in complementation with the local government units. So the basis for redevolving health functions to LGUs, specifically on which type of LGU, is due to the expenditure assignment of health functions per level of government. Basically, more complex services are given to larger forms of LGUs, particularly of hospitals to provinces, while the smallest unit of the barangays are to maintain their facilities that basically serves as an outpost for primary care. But I guess many of you hear that there are stories that some LGUs have difficulty in providing services, even with this reform. When we say increase in financing so that there would be increase in services, such finances have to be displayed into these or farmed out to these components from the human resources for health, health technologies, meaning not just the medicines and vaccines, but also the whole supply chain management, demand generation or health promotion, health governance, leadership management, health information systems, health infrastructure. When you increase your resources, especially if it is hard money, the next question is which kind of resource should you invest in or buy more of? Now it is more of a planning and allocation problem that may not be the same for one LGU to the next. So we could not be quite prescriptive. Here is where research and a carefully designed monitoring and evaluation plan could figure in, especially with a wide range of data elements to take into consideration to transform increase in financial resources to better services. So while there is an M&E being spearheaded by the Department of Interior and local government, independent studies are actually encouraged, as it will enable availability of more perspectives towards sustainable development. We have earlier said that we have over 40,000 local government units from the barangays to the cities and provinces, and there are more than that number of stories, perspectives that could, and case studies that could figure in helping one another in determining which kind of allocation is best, especially for the health sector with 100 different types of services. Since this part of the discussion is more of on a gray area still, I will next provide more concrete examples on how data from administrative systems are able to influence policy. So at the start of the pandemic, our team was tasked to try to answer how many beds are still available in each hospital all around the Philippines on a daily basis. So we had zero funds. We just borrowed people across the offices in the Department of Health to set this bed tracker. From Google Sheets to developing an app while searching for literature on what questions to answer and how to answer them, within 1 to 3 weeks, we launched the bed tracker with regular revision of versions to accommodate new data needs. So 3 years later, the information system is still functional, and we deem it as a good system in terms of being referenced regularly for policy decisions on whether to implement restrictions, for resource allocation or reallocation across provinces, across hospitals, and even for daily operations such as referrals. More recently, in the past 2 months, due to the impending effects of the El Nino, an electronic survey was quickly set up in a week that asks on service interruptions, preparedness, and technical assistance requests from licensed facilities nationwide on a weekly basis. Barely a month in its implementation, the greatest result we saw so far is that the survey was utilized in the presentation of the department at a national high-level meeting attended by multiple agencies across government, which generated a welcome response. In terms of the technical assistance requests, wherein other agencies try to pitch in how to help out the health sector in certain requests that are primarily on the engineering side. So usually the hospitals ask for generators, water pumps, tanks, solar panels, specifically for the service interruptions being experienced in the electricity and water side due to the El Nino. So what is clear in the two examples is that you should have an end in mind when conceptualizing what data you need to collect, so that when the opportunity arrives, we strike it when it's hot. Present it as simple as possible and end with clear asks from participants, especially if they are decision makers, so that there is a high likelihood of success and relevance. Do not be afraid to revise your tools, since public health is a practice. In the bed tracker, we had to go to 7 or so revisions to accommodate new developments on the field or taking into account user experience or a new context that we were not aware of when we were starting. No one system is perfect, no one individual is perfect, but what we have to make sure of is we continually learn and improve. While the former examples are quite direct in their feedback from the local to the national, due to the operational nature of the data being gathered, here are other programs or projects by the department that involve an end of implementation evaluation, as their outcomes may take years to manifest. First is the universal healthcare integration sites, wherein those local government units who committed to province-wide or city-wide integration from technical, managerial, and financial shall be assessed 6 years after the UHC Act of 2019 as to whether those who have integrated have improved their health system. But even with this 6-year evaluation, there is a monitoring system set in place, the local health systems maturity levels, that provides a roadmap for local government units that wanted to commit to province-wide or city-wide integration. Second is the newly launched multi-year Philippine multi-sectoral nutrition project that seeks to improve key behaviors and practices known to reduce stunting by increasing the utilization of a package of nutrition-specific and nutrition-sensitive interventions in targeted LGUs. Within its implementation, it is planned to test out a variety of interventions with grants, hard assistance such as commodities and soft technical assistance, and later on systematically assess which set of interventions would be most effective in reaching its objectives. So what is in store in the future? While the health sector strategies, monitoring, and evaluation framework will still be developed, what is clear is that there are traditional indicators as seen in the Philippine Development Plan that we monitor, especially for international commitments such as the Sustainable Development Goals. These are being tracked with the usual monitoring and evaluation systems we have. However, these are usually impact indicators to which we have established surveys like the National Demographic and Health Survey, which are done every few years. For the NHS, it's around 3 years. What remains to be seen and what DOH is working right now, especially with the learnings during the pandemic, is that what we need is quick data that is able to capture what is essential. And this is being done through organizational development, networking, and even legislation by sustainably improving the administrative information systems, such as if you are familiar with the Field Health Service Information System, and even the vast number of disease surveillance and response systems, so that all of these could be gathered directly through electronic medical records. However, these things could not happen without capacity building within and outside the department, from every point where data is collected, from point of care to data managers, to analysts, to epidemiologists, and data scientists. So this is where our private sector, the researchers and the academe could help in developing the capacity of all in terms of data science, epidemiology, and surveillance. Hence, aside from the research questions and research agenda, which DOH publishes annually, the future the DOH seeks, where our stakeholders can support, is the Philippine Centers for Disease Control, where a vibrant world of evidence-informed policymaking can be fortified with this proposed institution. So we look forward to this institution, and of course, the national government and all the local governments working together so that data and governance can work side by side. Thank you.
Thank you very much, Doc Gab. Really good to hear about the various initiatives around data and how those are being used, and the excellent examples of the flow of data from the local level to the national level and how that informs allocations, planning, and so forth. We hopefully can spend some time also discussing some challenges during the panel discussion. I already see one question on a challenge, particularly with healthcare workers. This is in the Q&A box. So for the attendees of this webinar, please feel free to send your questions through the Q&A box. There's a Q&A button on the bottom of the screen on Zoom, which you can click, and then you can send in your question, or you can also vote for a question if you want to prioritize some existing questions that are already there. You can click the thumbs up sign so that we can bump that up in priority in the panel discussion. And we'll try as much as we can to cover them in the panel. Please also, for the participants, please include your names and your affiliation so we can address you properly. Our next speaker is Dr. Dina Nadera. who will speak on her experience in bridging the gap between research and local policy by engaging local government. Dr. Nadera heads the Mental Health Science Flagship Program at the Center for Research and Innovation of the Ateneo School of Medicine and Public Health. A fellow of the Philippine Psychiatric Association, Dr. Nadera is actively engaged in different public mental health initiatives for government and civil society organizations in various capacities, particularly in the areas of research, capacity building, policy, and legislation. Please join me in welcoming Dr. Dina Nadera.
Magandang araw po sa ating lahat, and thank you very much to the organizers for this kind invitation. So in my presentation, we will try to revisit the life cycle of research data. And hopefully through this presentation, we will share some practices in carrying out a research and in implementing a capacity building project that illustrate how information gleaned from these engagements have led to its early utilization at the grassroots level. Okay, oops, sorry. Okay, so, oops. Okay, so the first part of the presentation will be about the research management and practices, and the second part will be the actual examples of the products arising from these practices. I am referring to the mental health access, mental health perception, access, and delivery when I talk about the research. The research is actually a descriptive research utilizing a mix of quality and quantitative approaches for the purpose of analyzing the mental health system at the local levels and understanding the community's perception of mental health, as well as access, utilization of mental health services. And my focus is actually about the information and utilization generated at the lowest level, which is the community. The capacity building engagement that I am referring to is the rollout of the Mental Health Gap Action Program in Maguindanao, one of the advanced implementation sites of the universal healthcare, and it is also the focus site, one of the focus sites of the Special Initiative for Mental Health Philippines of the World Health Organization. Mental health MHGAP, or the Mental Health Gap Action Program, aims to increase non-specialist care, including primary health care, in order to address unmet needs of persons with mental, neurologic, and substance use disorders. And it asserts that with proper care, many persons with depression, psychosis, and epilepsy can be treated, and that death due to suicides can be prevented. Okay, so what are the project management practices I am referring to? So I would like to share them, and these practices we have employed actually allow the data utilization at the grassroots level. So the practices were adopted because first, they were required by the project, of course, but there was kind of an upgrade, a modification on how we implemented or we were able to achieve that requirement. And another reason why these practices were adopted is because they surfaced during the social preparation before we went to the research sites, and they also were extracted during the project implementation. And another reason why we adopted this is because they were a means to advocate for public mental health. It was actually something we did not intend at first, but it became something that we thought should happen during the research implementation. And we also felt an ethical obligation to share the information we gathered to the stakeholders in the research sites. Okay, so the first practice that I would like to talk to you about is the exit conference. So, well, exit conference is usually done as an audit process, no, where the audit findings are presented to management in order to obtain comments about their findings before an audit report is formally written. But the exit conferences we held were done after the data collection, and we have processed the data already. And we actually invited the local, the stakeholders, referring to the health system stakeholders, the municipal health workers, the nurses, the barangay health workers. And because we were doing cluster sampling at the barangay level, we also invited the barangay captains in the research sites where we went. So the reason for that, for the conduct was to, of course, to present to them the findings, so that at least they have they have first knowledge about the findings, and comment on the interpretation and implication of the findings. So it actually served also to validate our research results. And the other thing that was very nice about it is the enumerators, the data collectors, were also in attendance, and they were, and in some exit conferences, there were also presenters, and they actively participated in the open forum during the exit conference. Many of them expressed appreciation of the process, where they recognize the value of their work. And we also learned that this kind of practice was new in all of the research sites. The other practice is what we call the X deal. No? So the X deals were actually considered when research participants and field coordinators were asking a lot of questions about mental health topics during the social preparation and again in the implementation. So at that time, most of the most common question was about the Mental Health Act. So this was 2019, and early 2019 was the signing of the implementing rules and regulations of the Mental Health Act, which was actually promulgated in 2018. So the other, so many were asking about what it was all about, and there were also questions about suicide prevention in the community, as we learned, and as we learned that there were suicide events there, and then there was also one who requested about, who requested seminar on bullying. So this was a school in one of the research sites. So for us, it was an opportunity to advocate for public mental health. And it's a kind of giving back also to the healthcare providers and an opportunity to develop partnerships. The other practice that we adopted was the operationalization. So this is basically systems building integrated into a capacity building instead of a plain planning session. Seminars and workshops usually have a planning session as its final activity. In the case of the MHGAP capacity building activity, the simple planning was leveled up to MHGAP operationalization in the community. So as I mentioned earlier, it was an opportunity to look at the mental health system in order to harness or optimize the benefits of capacity building. So what resulted from these kinds of approaches that were employed during the research management and also the capacity building? This resulted in two products, which may have been the expected output in the first place, or there were or unintentional consequences that proved to be useful even beyond the project. So some of these products include the policy brief. So policy briefs were expected output, was an expected output for the mental health perception, access, and delivery research. However, instead of making policy briefs just for one level, like the municipal level or provincial level, the team decided to make policy briefs at different levels. So for municipal level, as shown here, we did a policy brief on Katarman. And this was done still during the research process, where the municipal health officer was part of the team that drafted the policy brief. At the provincial level, we were able to do one for Zamboanga del Norte. And for this policy brief, there were the psychiatrist at the provincial hospital was a participant. And also we were able to get some feedback from the field team, the data collection team. And at the regional level, we were able to develop a policy brief for Region 4B or Mimaropa. Actually, there was only one province that was included in Region 4B. And because these are island provinces, we were able to consult the regional mental health coordinator and ask if the kind of picture that was researched on one province would be similar to the other provinces in the region. And she did agree that it was high time that that policy brief for this one municipality can actually be elevated into a regional policy brief. So the regional mental health coordinator was part of the team that developed the policy brief for Mimaropa. Now, one of the unintentional, but definitely very useful output is the resource mapping. So, of course, this was an expected output. No? You have like a table or a list of services in the research sites. But instead of presenting this as a list of resources, the mapping is now in the ACRI website and will be periodically updated based on the capacity building projects that ACRI has with the WHO Philippines. So right now, we are engaged in doing capacity building for MHGAP. Okay, so as I mentioned earlier, one of the most common things, topics that came out during the our field work was about the mental health explainer. So there was actually a request for an orientation of the mental health law during this process, and in partnership with non-government organizations and a media outfit, we were able to create a video that explains what the Mental Health Act is. And we used the languages that were the language of the research site. So this was Tagalog, Ilocano. These were Tagalog, Ilocano, Bicol, Hiligaynon, Bisaya, and Waray. I forgot to write Waray. So the videos are now used as part of an introduction to MHGAP to present the legislative framework of why we need to develop mental health services at the primary care level. So this is an example of something that was unintentional, that became a product of the research and is now even used beyond the research. So this is the print, the print version of the Mental Health Act explainer that can also be accessed at the ACRI website. Okay, so the common challenges of persons with mental health conditions that prompt consultation or disruption in the home setting that we were able to gather from the research were sleep problems, agitation or restlessness, non-compliance to medications, and reaction to hallucinations. Based on these findings, we developed a module on addressing common challenges of persons with mental health conditions. And this was integrated in the primary healthcare in communities webinar series held by the RGL Hub some months ago. A Tagalog version of the module was also used to train organizations of persons with disability. So again, this is an example of something that even during the research implementation, when we were able to get some information that was that needed to be kind of addressed immediately. You don't have to wait for the national data because we were getting similar results in different provinces. So this was immediately used in order to increase mental health literacy in the sites where we did the research. And even after the research was long done. Okay, earlier I mentioned about the operationalization. So this is the pathway that is gathered during the situational analysis prior to the capacity building project. And this is a required activity for the project. This is the example that we got for Maguindanao del Sur and Norte combined. So when we talk about operationalization, we did not just want to look at the service delivery network or the simple pathway, which was the basic requirement of the project. We applied this to one cluster. So you have Maguindanao as a province and you have clusters within the province. And this is the equivalent of an interlocal health zone. So we use the guidelines on the service delivery design of healthcare providers for universal healthcare, which is a DOH administrative order, to create a concrete picture of primary care and healthcare provider network. And this picture shows the possible support systems in place, possible support systems that are in place for the provision of mental health services in non-specialized setting. And this is drawn actually right after the capacity building activity. So immediately after the capacity building activity, they're able to picture how the services, what kind of pathways are within their services and what should be the ideal pathway of services. Okay, just as a conclusion, so this is second to the last slide. To conclude my presentation, I would like us to revisit the research data life cycle. So according to the Princeton Research Data Service, research data has a longer lifespan than the project. And the research data life cycle is a model that illustrates the stages of data management. It describes how the data flows through the research project from start to finish. But for our experience, it was really more of the data utilization that was almost simultaneous with the data generation. Data management, of course, will refer to the process of deciding and documenting on how the data will be collected, organized, stored, and shared. But what I would like to emphasize in my sharing is the fact that our experience, as I mentioned, illustrated production and consumption, generation and utilization almost coming one after the other. And the fact also that the conduct of research is in itself an advocacy. And the fact also that the projects develop mental health literacy. And we, of course, know that one component of mental health literacy is knowledge of where to seek and how to seek help. And this kind of mental health literacy was emphasized when we were doing the operationalization as part of the capacity building. So my last slide is one of my favorite stickers. It says, mangarap ng malalim, And these are discussions about research that's, that sometimes it's very high level. The conversations around research are high level, technical, ambitious. But let us not forget that aside from looking at the greater heights of to which research brings us, there is really a certain depth that we need to build in the community through its proper use. So that is all, and thank you very much.
Thank you very much, Dr. Dina. Really interesting to see that research cycle. I think often there's an impression that the research process is very linear, that, then there's a lot of focus on just the findings part. I think the examples that you gave really focus a lot on how do we translate those findings into use in a very practical way about, having the exit conference, how to engage with the LGUs, with like X deals. And I think also you put it as unintended products, but I think it's also a reflection of the agility and the way that you are finding opportunities to maximize the research output into more useful products to go beyond the life of the research itself. Thank you very much. We'll explore a few of these things in the panel discussion further. All right, our third speaker is Dr. Olga Vertusio. She will be speaking on her experience in leveraging data for effective decision-making within the context of a local government unit. Dr. Vertusio heads the Parañaque City Health Office, overseeing and managing the healthcare services and programs of the city. As the Chief Health Officer, she plays a crucial role in ensuring the health and well-being of the community, working closely with local government officials, community leaders, and other stakeholders. She also currently serves as the interim president of the Philippine Association of City Health Officers and the president of the Association of Health Officers of Metro Manila. Let's all welcome Dr. Olga Vertusio.
Hi, thank you very much, Aya. So a pleasant afternoon to everyone. Let me first share with you some quick facts about Parañaque City, a city with a population of 704,900 and a total land area of 46.57 square kilometers. It has 2 districts and a total of 16 barangays with 8 barangays each district. Parañaque City is a mega city by the bay, boasting of an entertainment city with a 5-star hotel along the bay. And now with a newly licensed second city hospital, Hospital ng Parañaque 2, with a dialysis and an ICU in our Hospital ng Parañaque 1. The 16 health centers are mostly with an ongoing process of our e-consulta, EMR, and e-claims to cope with the demands of the universal healthcare. So this afternoon, I will be sharing with you our programs where we were able to develop and utilize local data-driven policies, which were experienced at the local level. So here, displayed are some of the information systems, monitoring, and evaluation tools employed in the city to drive its public policies, planning, and health services. So one of the tangible programs of where the evidence-based data prompted action Okay, thank you. Prompted action from our policymakers was really our adolescent-friendly health information system. This was a project with Save the Children, and it was very successful in terms of program sustainability, which was based on its data-driven actions, interventions for the adolescents. AFIS was started in 2006 through the establishment of our adolescent-friendly reproductive network, which later on expanded throughout the city. The data was collected through targeted surveys and manual data collection analysis. So this data was used to develop more policies and services oriented for the adolescent population. This led to a citywide implementation within 3 to 4 years. Another successful implementation of public health services and other capacity building activities for our adolescents, adolescent peers, and as well as our peer educators. So the data-driven activities, which led to the establishment of youth-led organizations and a significant decrease in the risky behaviors. It also paved the way for funding activities such as capacity development sessions for our health service providers, increasing our CSO partnerships for priority psychological concerns, program implementation reviews, local and international recognitions, and partnerships. So another tool which we were able to use was through the assistance of our WHO and the Department of Health, where Parañaque City engaged in a short course on urban health equity, or they call the SCUHE. This was back in 2008, which led to the development of an urban heart tool, or health equity assessment and response tool. This looked into both the health system indicators and social determinants of health, looking into the physical environment, social and human development, economics, governance, and health outcomes. However, since only 2 cities were identified at the time to implement this beautiful project, we needed to scale up to other cities, and this paved the way to the identification of another tool which would provide data for program monitoring at the local level. And with this data, it had led to an increased interagency cooperation within the LGU, which led to the ramping up of both the human development services that directly and indirectly affect the health outcomes. It gave birth even to the development of a locally developed health information system. Our urban heart, actually through the years, were strengthened with the efforts in addressing health inequity in the local health sector. And this achieved the establishment of the first birthing facility in the city, which is the Paanakan 2, the establishment of the first information system on pregnant women in the local barangay. And with this at hand, the creation of a city resolution to strengthen further the project. Resolution 08055, the series of 2008, and an ordinance which gave way to a regulation of the birthing facility. In this further increased actually the awareness of the risks in home deliveries, our newborn screening, and breastfeeding practices, an increase in the utilization of health facilities and the delivery. The regular submission of reports were facilitated from PNP, Senro, our CESU, Budget Office, Planning Office, and MMDA. So the integration of the LGU scorecard and the urban heart indicators was facilitated as well. And the establishment of our first ever service delivery network, which provided for an increase in the compensation and partnership of our private midwives. This tool strengthened actually and activated our multi-sectoral partnerships at the local level. So glaringly, there was an increase in the awareness of our local leaders to establish the birthing facility in their local barangays, realizing the help that these facilities has brought to their communities. The urban health citywide implementation paved the way for disaggregated data at the barangay level, and the regular monitoring and implementation, as well as evaluation of the task force, which was created and scoped. The urban heart actually contributed to the development of the DOH LGU Health Scorecard, which is currently being implemented. So the LGU scorecard serves as the basis for the local health priorities and initiatives against the background of a national health agenda, using the program-related health outcomes and indicators with a mix of governance and local health system strategies. Currently in transition towards adopting the integration milestones developed for the universal healthcare integration. As a universal health integration site, the city also adopted the local health integration maturity level monitoring to guide the local health office in preparing, organizing, and functionalizing its health system towards the universal healthcare. It aligns with the policy and direction of the DOH towards the initial implementation of the Universal Healthcare Act and provided a basis for funding and implementation of the urban health integration activities to achieve key result areas. There is another tool which actually helped us, especially during the pandemic. And this is the coordinated operations to defeat pandemic, or the code, which I think only Parañaque City was able to implement during time. But I would like to share this with you because the data collected from the different health facilities and the local epidemiology and surveillance unit guided us through the different weekly meetings, which was held with the local COVID task force with the mayor. The trends and the key pandemic indicators were regularly reported to monitor and evaluate quarantine and community control measures, policies, and interventions, such as calibrated lockdowns, prevention messages by the mayor or by the local leaders, and our information and education campaign materials. So the weekly monitoring through the data sharing opened up the barangay's creative way of providing intervention and actions. And real-time status report were also provided by them and guided by the City Health Office, which led further to a stronger bond among our local chief executives, the policymakers, the health workers, as well as the different teams and the other multi-stakeholders. So as you can see, the various tools, facilitative as they are, is not without difficulties and challenges. So despite it provided us with very good areas of looking into our data, it as well provided some guidance. And foremost, the LGUs need to cope with the overwhelming need to shift to a digital era in terms of the citywide health system, changing mindsets for the digital services, an IT-capable workforce, overhauling the old from the new for the new workforce, capacitating the health workforce, hiring new generation, trainings, equipments, increasing awareness of the other sectors. A lot of funds for that. So these challenges will also we need also to move forward despite our challenges. And this is exactly having to look into the various tools to shift towards digital health data and information for a more timely decision and planning, which should be hastened. There's a need for us for additional encoders to unload burden the frontline health service providers, the need for local capacities, both technical and infrastructure, such as data management centers, servers, local hosts, and information system analysts, the need to review by the civil service or the DBM, the plantilla positions, attuned to the needs of the universal healthcare digitalization nationwide. The data privacy concerns is related to data sharing with the national and local agencies, which is very important in terms of data, health data that should be immediately at our hands. reliance on national capacities for data repository and systems developed for digital health information. Hence, with this, we just have to express that with the data collection, the sooner the better, is always the best answer. So that is the last slide. Thank you very much.
Thank you very much, Dr. Olga. Really interesting to see all of the various initiatives and the specific uses you had of the data that was collected locally. Also interesting to see the challenges, which hopefully we can discuss a little bit more. But also in the panel discussion later, I'd like to ask you a bit more also on the enablers. You know, what made Parañaque City able to have all of these initiatives that I think in general are difficult for local government units. Thank you so much, Dr. Olga. Okay, we can move then to our final presentation. For any questions that you may have, please send them through the Q&A box at the bottom of the screen. If you can click the Q&A button, please share your questions there so that we can address them in the panel discussion later. You don't need to wait for the panel discussion. You can send in your questions right away. And as I mentioned earlier, you can also vote on questions that are there to bump them up in priority. So feel free to put in your questions. There is an option to ask your questions anonymously if you prefer. So please go ahead and share your questions so that we can collate them for the panel discussion. Our final speaker for today is Dr. Alice Redfern from IDinsight. Dr. Alice is a clinically trained doctor with over 5 years of experience in public health research and development. She currently manages 2 partnerships of IDinsight with the Philippine Department of Health. Dr. Alice will share her insights from our work at IDinsight over the last 3 years in health promotion and the ongoing partnership we have with the Department of Health Promotion Bureau to conduct the 5-year National Health Promotion and Literacy Study. Please join me in welcoming Dr. Alice Redfern.
Thank you, Aya, and thank you to all the speakers that have already presented. I would just like to share that for IDinsight, one of the big motivations for this event was to learn from everyone's experience around these challenges of getting data down to local governments and making sure that they can use it. And I've already learned a lot from all of the different applications, so thank you for that. For today, I want to focus, as Aya mentioned, on the learnings that we've had from designing research, specifically related to health promotion work that we've done in collaboration with DOH and local government over recent years. We've been working with DOH for approximately 3 years now, started in the middle of the pandemic with some very rapid surveys looking at COVID knowledge, attitudes and practices, first working with Dr. Olga and her team at Parañaque City Health Office, and then working on a national study with DOH HPB. This has led us to where we are today, which we have an ongoing 5-year longitudinal national study capturing health literacy and knowledge, attitudes and practices across core health promotion pillars. And a big question that's come up in this study is trying to get the level of data right for the different decision makers that are involved across the health system. I'll speak more on this later, but we know that there's a lot of value in collecting rich national data, but you can't leave all the local governments behind in this. They also need data. They need to have the ability to ask their own questions. And we're thinking about that as well as part of our project. So what I want to really talk about today is some of the things that we've learned from this experience. I think we're still learning at the moment, but what's very clear to me is that there's a very big demand within the Philippines and across all levels of government for high quality, timely data. However, as we've seen, there's a lot of limitations and a lot of constraints in play as well. What we found is that there's a really clear demand to have subnational level data and to funnel that back up to the national level. But what it requires is very large sample sizes. It can be really costly and time intensive. And there's a lot of variation from one local government to another about what's available, what's possible, and what capacity exists and what capacity building is required in the future. I've just summarized here some three thoughts that we've had about what we can do to try and address some of these challenges. The first is to try and, at the design stage of the research, invest a lot of time in understanding the data needs at different levels of government. As we've seen, the national level needs are very different from the local level needs. I think Dr. Gab highlighted this very well in his presentation at the beginning. The decisions and the priorities may be very different. Second is adapting the methods according to LGU context and their existing resources. There's some really amazing work going on with the community-based monitoring system to capacitate all LGUs to conduct data collection, but it's at very different levels at the moment. And while that's being implemented, there's really a need to adapt methods in the meantime so that everyone still is able to use data for their decisions. We also have learned that there's ways that we can innovate on study design so that we can deal with these constraints and still yield useful results. For us, it's about right-sizing the data collection for the question that we have in mind. So just coming to the first point on these, I want to focus first on the experience that we had conducting national and local surveys around COVID, knowledge, attitudes, and practices during the pandemic. What I want to highlight here is just how different the national and the local data needs can be. When we were working with the Health Promotion Bureau on this topic, it was really clear that they had to make very quick decisions about the content and the messaging of national online campaigns. That's a little bit in contrast to Paraneke, who had to make equally quick decisions, but what they really needed to understand was the individual care-seeking behaviour patterns, how people were coping with lockdown, and what they could implement to support people locally as they went through the lockdown. We conducted quite similar surveys in both cases. We conducted rapid online surveys and followed up with phone surveys with a randomly selected sample. But ultimately, the outcomes were quite different. For HPB, the data that we used, they were able to rapidly develop television and radio campaign messages about how to slow the spread of COVID-19. But for Paraneke, we were able to share some very specific learnings about how socioeconomic groups were facing barriers to care, about the messaging that was being delivered in very local areas, allowing them to target support for them. So for us, what this means in future research projects is just really at the design stage, investing time to understand what those priorities are. And when you design surveys, making sure that not just the national level research questions are addressed, but also that local level research needs are addressed. And we recognize that they're not always the same. The next piece I want to speak about is on adapting methods according to the LGU context. As I mentioned here, we have an ongoing study at the moment. This is the National Health Promotion and Literacy Longitudinal Study. This is a very large nationally representative survey that we're planning to conduct every 6 months over the next 5 years. We have enumerators in the field at the moment collecting data for this, and there should be results available in just a few months. It's a very rich data set that we're hoping will be able to inform national campaigns, policies, and track resource allocation and trends over time. The problem is that we're very well aware that an exercise of this scale is far too resource intensive at the subnational level to really provide local governments with data from it. We're also aware that that might not be the right answer. Local governments may not need to get data every 6 months to track indicators over time. They may need to respond to questions as they arise in their decision making. They may need data less frequently, and they may not need data in such a representative group. They may just want to look for a specific target population. So while we're working with the Department of Health Bureau on this piece, which is the national level study, we're also trying to design an approach in partnership with HPP and LGUs for them to be able to conduct their own data collection as well. So our goal with this part of the work is to capacitate local governments to conduct their own health promotion surveys according to their needs, and to allow them to do their own local data use and their own decision making, and to be able to track indicators subnationally less frequently than every 6 months, but still frequently enough to be useful for decision making. We have some ongoing capacity assessments with CHDs and PHOs. And one of the big things that we're learning from this is that For now, at least, the same approach may not be possible in all LGUs, and we may need to target our design and our method according to the current capacity and availability of resources within the LGUs. Here are some of the examples that we've been considering. So in some LGUs, we know that there are already very strong regular data collection efforts. In areas where there's community-based monitoring system or where FSHIS is already up and running, there are enumerators there. There are people who are trained and are able to conduct this data collection. In those areas, it might be possible to do something like a rider survey where you're able to incorporate very timely research questions for that local government into ongoing efforts, perhaps just with a subsample. So that's one option that we're exploring. We also know that in urban populations with high internet usage, we've had some experience conducting surveys using online sampling approaches that allow for very quick turnaround surveys that give you a very representative sample of the population, even if it's not as rigorous as normal sampling approaches. Then finally, we know that in some LGUs, while there's ongoing efforts to capacity build, at the moment, there might just not be the right resources in place, or there's no ongoing data collection to build on. And in those cases, we think those are the LGUs that would really benefit from collaborating specifically with external researchers to learn as they go, to work on the job and do a project in collaboration with a researcher, and then to be left with the capacity to do that research in the future for themselves. I'm sure there are more options than this, and I'm excited to discuss and hear more about this when we get into the panel discussion. Finally, I just want to speak a little bit on innovating on design in order to deal with some of the constraints that we've been talking about. There are a large number of very large national studies in the Philippines. We've spoken about a few of them over the course of this discussion already. NDHS happening every 3 years, and the Universal Healthcare Survey, which will be starting up hopefully this year. And now we're also conducting this health promotion survey, which will be getting data every 6 months. But for a lot of LGUs, that might not be the right answer. I think sometimes it's very important to accept that maybe getting a full, perfect representative sample is not the answer, and there might be quicker, lower cost, but still decision relevant ways to collect data in order to inform decisions. Here is an example of a study that we did, as I mentioned earlier, during the pandemic. What we actually did for this was we used targeted Facebook ads in order to identify low-income residents within the Parañaque city. From there, we were able to randomly select respondents who opted in for that phone survey and randomly sample people to follow up on the phone and ask various questions about their response during the early pandemic. The sample was not perfectly representative, but if we look at the breakdown of respondents that we got, it was very comparable to the population of Metro Manila in terms of age, gender, family size, and the distribution across different barangays. And what we were able to do was conduct 600 surveys, and it was within less than 2 weeks, and it was less than a month from when we started till when we were able to disseminate results. And that was very important in terms of making sure that the data was used. And I think echoes the final point that Dr. Olga shared about sooner is always better with data collection. And for us, I think that's very important in terms of making sure that that data has impact in the moment when it's required. There might be cases where the right answer is to do a very large representative study, but I think that as researchers, it's on us to try and think of ways we can innovate and ways we can support decision makers that might compromise a little bit on the technical rigor, but still give them extremely useful and valuable data for decision making. Great. And that's all from me for today. And thank you very much again to everyone who's joined. And I'm looking forward to some discussion around these topics.
Thank you very much, Dr. Alice. Now we can proceed to the panel discussion. I'd like to invite our speakers to join us and turn your video on so we can get a chance to further discuss some points raised earlier, as well as some questions from our participants. I'd like to remind again our participants that you can send your questions in the Q&A box. We've noted 3 questions already, and we can discuss them in the panel. I'd like to just give a bit of framing in this panel discussion. I don't think we're in a place to provide all of the solutions, all of the answers in this in the aspect of data and devolution, I think we would really want to have this opportunity to discuss challenges, explore possible solutions, and work in a very collaborative and open and honest way. And so, yeah, I would encourage that kind of thinking for the audience as we ask our questions, and for our panelists as well in responding to the questions. I wanted to start with one question from my end, and then we can proceed to the questions from the panel, from the audience, and I'll call on the panelists, whoever wants to respond. The first that I wanted to ask was on capacity building. So we often hear this, that there are challenges in collecting, analyzing, using the data at the local government, but also actually all across the levels of government. So I wanted to maybe pose a question to our panelists about what you see are the biggest gaps in terms of capacity, and what can be done to address these gaps, drawing on not just resources from the government, but from collaborators as well, from the academe. We have our representatives, Dr. David and Dr. Dina here, and other researchers as well as Dr. Alice. Maybe I'll start with Dr. Olga and Dr. Gab for the perspective from government, and then open to others as well to respond. Go ahead, Dr. Olga.
Yeah, actually from the local level, when you talk of sorry, and what was the question?
The question is about what are the biggest capacity gaps that you experience, or maybe also I was asking earlier if you can share some enablers from your end, like what are the capacities that actually the Parañaque City Health Office has that allowed you to do this that might be a capacity gap for others. So asking about the capacity gaps and ideas for addressing those gaps.
Okay, sorry, was interrupted by one of my staff. Anyway, capacity gaps at the local level in the implementation of our programs. For me, when you talk of capacity, that is capacity building and providing and equipping actually the healthcare providers in terms of program implementation, depending on the kind of program that you have to implement, is very crucial, no? Because you can introduce so many programs, but without providing that capacity and providing that enabling environment as well as providing the environment for the health workers, it will be a little bit difficult, no, for us. So for Parañaque, so far in terms of capacity building, we have been supported, no, on this by in terms of through the Department of Health, through partnership with the Department of Health, the technical services that technical trainings that they provide, the support from the local government through appropriate funding, through proper connections in terms of providing them the orientation and the proper information that you have to inform the local policymakers that this is necessary in terms of providing this capacity building, no? And I think primarily also the place where you have to provide, no, the trainings and the very structure where they have to conduct the training. All of these things I think should be considered as well. And initially we have those gaps, but already these were addressed and are presently we are in the process of renovation and the provision of these areas as well for capacity building. I think that's about it for me. Thank you.
Thanks so much, Dr. Olga. Dr. Gab, do you want to chime in?
Yes, I think Dr. Olga has captured well in terms of the local level, which is actually similar across various localities and even at the regional levels. But what I'd like to highlight, possibly at the national level, is the capacity to design information systems, going even at the basic of what question do you want to be answered. So those simple questions, research objectives that are not inculcated in terms of how we design our information systems. So that is why during the pandemic and even 3 years after, we see that the past information systems that have been developed and used, even if there's a wide data collection, these are not contributing enough to the discussion at the policy level of what things do we have to change, what systems do we still have to work on. And maybe later I'll try to answer the other questions, but basically these system design and development capacity is what is maybe crucially lacking or limited in terms of our health sector.
Thanks, Doc. I'm turning to Dr. Dairit and Dr. Dina if you have inputs on that, on either maybe a way that you have worked with local government to help bridge some gaps, or if you have comments also on data systems in particular that Doc have mentioned.
Yeah. Sige, sir,
Okay,
go
Dina,
ahead.
you go ahead. You go ahead, Dina. Follow.
Well, I'm drawing my answer from the experience regarding mental health capacity building. What we have observed is whenever we do capacity building activities, but the health system does not provide an environment that enables the capacity to be practiced, then we have a very big gap. Let me give you one example. It used to be that whenever we do training on mental health in primary care, there are no medications that are provided to the primary healthcare workers, okay? So even if they are trained on the medications, but they don't have that armamentarium, they cannot actually practice that skill. In that case, it is actually the health system that should enable them. Sayang yung pera, right? The other thing that we have observed is the presence of post-training support and supervision is very important, particularly for conditions where specialists are very few. Again, I'm citing our experience in mental health in primary care. The target of the WHO, of the Department of Health, is the number of persons trained on this specific program. Okay. But what about the referral system? If they're looking at the number of primary care providers, there should be a referral system that is also built. So the training has to be modified in such a way that it does not target only the primary care workers, but it also targets the level 1, 2, and 3 hospitals. Nonetheless, there are very few funds. Before, there were no funds for the hospitals. So the primary care providers are not confident. No, they lose that confidence because if they are not able to manage at the primary care level, there is no upward referral to the higher to the referral centers, no, to the first level referral centers. So I think that's basically what I wanted to say. The health system should provide an environment that enables the healthcare workers to practice the skills that they learn during the capacity building. Thank you.
Thank you. Let me build on what the 3 other speakers have said, and I'll try to simplify it. But I think the first thing really, big capacity gap, is really a collective understanding, within, I guess, society, within the health sector and outside, of where to start to build capacity. And under a collective understanding there. The way our society works is you have to have a law. And essentially, it's the legislators that come together, come up with a law, and then you implement it. But concurrent with creating a law is really developing that collective understanding of where you're going to build capacity. Once you have that, I guess then things will start falling into place, no? But with that collective understanding, you can then build a roadmap, which would include cogent plans, policies of how you build your data system. I think this is what Dina refers to as the health system being unable to do that. With that roadmap, you can determine your priorities, and then you can determine your investments, which is again a capacity gap because you don't know exactly, what you're going to build. And then with those investments, you then have to bring in, all the warm bodies, decide on the people that need to be trained, decide on the different categories of people that need to be trained. They're probably already out there and being trained in the schools, but then you can start to assemble and organize them into units, within your public sector as well as within your private sector. And then create the facilities for data management as well as your supportive infrastructure. So I think when you talk about a capacity gap, it's a gap in the conceptualization of where we want to go. And then coming from there, how you're going to do it. Okay? The investments and all of the capacity building and training and facility building that you need to undertake. Thank you.
Thank you, Dr. David. Dr. Alice, any insight from your side?
Sure, not much to add from that. I think it's all been made very succinctly. I would just say on Dr. David's point, I think this is something that we have seen again and again in IDinsight. I'm often struck by just the sheer volume of capacity building that's going on and the sheer volume of expectations that are trickling down first to CHDs, then to PHOs, then to the healthcare providers. Cumulatively, it's really a lot. And I think it's quite unrealistic to expect that all of these things are just then going to happen as a result of that capacity building. So for us, as we've been thinking about our own capacity building exercises, that's been on our mind, is how do we actually not just be another capacity building session that doesn't get listened to or can't be enacted on because people don't have time because they have another session to attend afterwards. I think that's a real challenge. And I think that what would really help is having focus, as you say, on what's the envisioned reality for the capacities that should exist across all local governments so that we can work towards that together.
Thank you, Dr. Alice. I'll move to one question that we have that actually builds on this question on capacity building. The question is that in this devolved data system, there can be very wide variations in data availability and quality among local government units that may lead to disparities in health information access. I'll add to that, I guess this is also because there's such a wide variation in resources of local government units, from highly urbanized cities to the lowest income municipalities. So the question is that apart from capacity building, and I think capacity building tends to be in their language like synonymous to trainings, but apart from capacity building, what are some other things to do to level that playing field? I'll invite the panelists, if you want to respond, feel free to unmute yourself and then you can respond to this question.
Yeah, I'll try to answer.
Sure, Dr.
So I earlier said regarding the information system design. So similarly in our efforts in the pandemic and recently, so it's about making sure that the data you want to collect is actually usable even at the local level from the data collector side. So in the past, or in other kinds of information systems, the utilization of these data are only used at the national level, not even sometimes at the regional level. That's why it's not the quality and the timeliness and the availability of these data are not as sufficient or quality as we would like to see. But similar in terms of Dr. Olga's example of the code tool, they were able to use it for their own purpose. So that is what I would like to see, what the DOH would like to see as well in information systems in the future.
Dr. David?
Yes, thank you. You know, I recall a situation sometime when I was starting my public health practice, where I was in the office of the Secretary of Health, and he was having to make a decision. And he didn't have any basis for making his decision. There was no data he could rely on. And he opined the fact that the Filipinos, particularly, you know, as we were evolving as a society, was not a very data culture type of society. Very, very anecdotal and very, very subjective. That was just the way we were, you know? But that was many, many years ago, and I think we've moved forward. And now people do demand data. So I think aside from capacity building, what we really need to do is to continue to strengthen that data culture. Get people to be able to provide evidence and proof for what they say. Bring your discussions to a higher level of objective facts, rather than, you know, pulling rank or decide because you're the head of the hierarchy of the organization. So it's really that. It's getting that data culture and all the way down to the communities, because it's in the communities where it's very hierarchical. You know, what the mayor decides, that's it. What the governor decides, that's it. And essentially, you have to question, in a way, that way of doing it. And because of that, it becomes very, very, you know, political and hierarchical. So it's improving on the data culture. And without that data culture, even if you build capacity, you know, you might be acting in a futile way, because the people that have the power won't listen to any of the data that you present. And so I think it's important that population itself in general becomes attuned to evidence and to facts, and not to fake news and not to misinformation. Thank you.
Thanks, Dr. David. Dr. Olga? Go ahead, Dr. Olga.
Yeah, very short. I would just like to concur with our good Dr. David mentioned, and of course, Dr. Borlongan, because at the local, I will be responding at the local level, no, and our difficulties, which I was also able to express during the presentation. So aside from the capacity gap, I think it's very important that, especially for the universal healthcare implementation, we saw the need also for the national leaders to inform and capacitate our local chief executive. Because in terms of information, I think it's so difficult for us to convince them as well, no, that the importance of the universal healthcare. We feel that their knowledge on this is not enough, and how really to implement. Second, when the universal healthcare was actually handed down to us for implementation, I think the cities were not really prepared. Being an integration site, I must admit that it was a big challenge for us. But because we wanted the UHC to be implemented in our city, we really opted to be an integration site. So we fast-tracked the very system that we needed. The data, which was mentioned actually by our Dr. David, is very right, because for us at the local level, it was during the pandemic time that the data helped us a lot. The data from the national and through the monitoring system that we were able to do, it helped us address and take action immediately. No, data and the tools as well as the very templates, even the tools that we have to use in monitoring this data in the different barangay were very important. And the regularity of meetings and monitoring. You don't hand down programs to us and leave us to just implement. It has to be monitored and it has to be moved forward, not just handing it out to us. And one more thing, I think more than the capacity building, again, I couldn't reiterate more the need to equip the LGUs. When we implement programs, you need the funding, you need the equipments, you need the manpower. These are the very gaps that actually hinders us from implementing various programs, beautiful programs that limits our capacity actually, even to learn, even to know how to do it in information technology, digitalization. I think that's the way to. Thank you.
Thank you, Dr. Olga. We'll move to a set of questions that are somewhat related, so I'll connect them together and then please feel free to respond to them. So there's a question about having, how can a standardized data framework be developed and implemented across local government units? And what are the prerequisites of having such a framework? There is also a question on UHC in particular, but I think somewhat similar. So how do you prevent the need-responsive development of tools for information acquisition becoming largely ad hoc for UHC purposes? So given the UHC's lofty goals, are there discussions on having standards for data acquisition, reporting, and management toward UHC implementation? I am looking at one more. I think one is a little bit related, so I'll throw this in if you want to answer it. On when collecting rich data, which processes can one use to prioritize data for evidence-based decision-making by national and provincial government? Talking about frameworks, standardizing across various LGUs. Would anyone in the panel like to answer?
I'll try to start again. So in terms of the various M&E frameworks, so for the monitoring and evaluation framework for the health sector strategy, I think it would be developed. It's still under development, but basically there are quite a number of monitoring and evaluation frameworks and even systems across the various programs. So even in the public health services types of programs, there are more than 30 of them. Not all of them have their own M&E frameworks, but many of them have their own information systems. So the direction now is how to mobilize the electronic medical record system to be the source for all these information systems at the top. So it would be more of extracting on these rich source already. So for this, the RISE PH is being developed. It is a routine information system repository kind of system that would basically be the ones to receive from all the various electronic medical record systems across hospitals, facilities. And it is through this repository that the various disease-specific, program-specific information system will be sourcing out. But it would take years for this to happen. So what could be done, what is also being done is in terms of standardization of the data and health-related data as mandated by the Universal Healthcare Act. So for this, the DOH and PhilHealth started developing the health data standards, consulting with the various groups that develop data standards for all kinds of health-related data. But it may take some time for these to manifest, since similarly in other countries, it took them years or even a decade for these to manifest. But hopefully it's a right step forward.
Maybe I can just build on that quickly. And just to say, I've seen a lot of amazing efforts in the Philippines for these integrated systems, but I think you've summarized it right, that it's going to take some time for us to get there. So I think that while there is a need for standardizing, there's also a need for a bit of agility and flexibility in the meantime while those systems are coming in. And I think, yes, there may be differentials between the amount of data that's available at different local governments, but I don't think that all local governments are going to get to the same place at the same time. So I think while they're along the way, it's okay to accept that things are different from one local government to another and to support them through that process so that they can learn more along the way. And I think that's one thing that we've been thinking about a lot, is not expecting the same thing from every local government on the first day of the implementation.
Thanks, Dr. Alice and Dr. Gab. Dr. David?
Yes, you know, that's a very hard question to answer. No? But trying to wrap my head around a possible response. I was thinking that we would first have to understand our data sources, because our data sources include, for example, vital statistics, which is collected by Philippine Statistics Authority. So that's birth, that's deaths. And then hospital data. And most of the hospital data, you know, is actually captured for individual inpatient care in PhilHealth. So insurance claims would be another source of data. Program data, a lot of that is vertical, because programs are vertical and they collect their data. And for example, data of individuals themselves, assuming that they have electronic medical records. So I guess trying to understand how this constellation of data sources can then be organized so that you can mine them and then eventually analyze them according to your priority needs. But I think in order to do that, we'll have to digitalize. And as you can see, a lot of our data collection is still manual, particularly at the center level, and even in many of the district offices. So I think that there are two things that need to happen. One is thinking about those data sources and how you standardize their collection, and then working out a plan to digitalize them and make sure that they come together so that you can analyze them according to your priority needs. Thank you.
Thank you. We'll maybe go to one final question before we wrap up. I'll pick the one that has the most votes, which is, how do we address the reality that our existing health data does not capture Filipino patients who are disenfranchised and no longer transact with public health institutions? These are the patients who go out to small private doctors and get their medicines not from the health centers, but from small community pharmacies. Poor service reliability drive patients away. If we don't address the gap, forecasting demand and budgeting would always fall short.
I'll try to answer again, Ayan. So in terms of these kinds of information that are not reached by administrative information systems, this is really why surveys, while very nimble or tedious to do, are quite valuable, since they provide a better or more accurate picture while not being precise at the more subnational levels. And also in terms of analysis, if you are use administrative data, there's something we call sensitivity analysis. So we use some situations wherein we adjust the data based on what kind of limitations we have in terms of the sources we have right now. Over.
Thanks, Dr. Dr. David?
Yeah, maybe just quick answer to that out of Dr. Berlongan. Marginalized people, if they're out, and that happens even with PSA. Many of our countrymen don't have any birth certificates. They don't have any death certificates. So I guess the approach there would be very purposive. And as Gabriel said, you probably need to do targeted surveys for them and try to ferret out, their needs until you can bring them into the mainstream. Thank you.
Thank you, Dr. David. Any other thoughts from our team of panelists? Dr. Alice?
I can share a few quick thoughts. I don't have a good answer to the question. It's a difficult one, but I can say this is an aspect that we have thought about in the design of our research. I do agree that ultimately surveying is the answer here, in that it gets you access to those people that are not already represented in the data. One thing that we think about as we're designing studies is making sure that across all the different studies that are going on are the different populations represented. I think often we treat a lot of these large national or even subnational studies completely independently, but what we can do is look a bit more cohesively across all of the different surveys that are going on. They all have their strengths and their weaknesses, and just try and make sure that across them that all of these different populations are targeted. I think as an example, we are working on designing this UHC survey and on the health promotion survey at the same time. I know that with the UHC survey, we're really interested in the actual interactions with universal healthcare as it's being implemented. So we focus on facilities and patients interacting with the system, but we know that we avoid and miss these people that are being alluded to here. But then we know from other surveys, so the health promotion survey, that's completely irrespective of engagement with healthcare. So we get additional data. So really, I think it comes down to triangulating data points across all of these different resources and making sure that you're mindful of not missing people by just using one data source.
Great, thank you, Dr. Alice. We only have about 5 minutes left, so I would like to wrap up by asking each of our panelists for their final thoughts in maybe 30 seconds. If you can share your final message to the audience, you can choose to respond to any of the other open questions or kind of a summary of your thoughts on this topic. I will just call on, Dr. Olga.
I think for my final sharing, I would just like to say that I'd like to thank IDinsight for this opportunity to share what we're doing at the local level. But most of all, I would like to also share that I think most of the other cities probably who are on board as well, that we are moving towards a highly data-based program implementation already. And this is because one of the areas we're working on is really looking into the profiling of the communities at the local level. And part of that profiling is to include the status of each members of the family. And we're looking at the, when you asked that question, actually, I was really thinking of like sharing that through the profiling, we will be able to probably more than the survey is really looking into the various healthcare providers at the barangay level to look into this the profile, the profile of each barangay, and to identify already vulnerable groups. And with this identification, and again, the digital way to do it is very important for us. And that is one of the moves that we are doing, which we hope that the national government can really help us at the local level. So I think, yes, for us, the data both surveillance and monitoring the different outbreaks, the different possible disasters that might come, the need for medications of the patients, to the data profile, which it's actually ongoing right now, will be the way to go, for the universal healthcare. It's really digitalization for us as well. So yun, thank you very much.
Try to
Dr. Yes.
So there's so much data around, but some are useful, some are not. It's about knowing how to use them, knowing and discerning which ones would be best for you. Likewise, when starting a new information system or any effort similar to that, we ask ourselves, what is the story we want to tell? Since at the end of the day, any information system, any data collection is not free. It has a burden to the data collectors, the managers, the analysts. And lastly, thank you to IDinsight for providing this platform. It was a good platform for the audience and also for us in terms of energizing us towards providing better data for good governance.
Thank you, Dr. David?
Okay. My final thought is this. The UHC law was a landmark law that gave strategic direction to the health system. And it's very clear, the health system, the health sector is moving in that direction. My question is, will the community-based monitoring system law do the same for data system? Because what it purports to do is to bring all stakeholders into the fold. And that's PSA shepherding all agencies, including local government. So that's my final thought, because that will mean moving towards good and effective digitalization, and national integration of data systems is the key word, which is so difficult. Thank you.
Thank you, Dr. David. Dr. Dina?
Yeah, as a researcher, it's always our, we are always willing to generate data. That's our wish. We generate good data, reliable data. And from the ground, we talk about data generation, it's always coming from the ground, going up at the national level. One of the things that is concerning right now, at least when I work in the ground, is how soon does this national data trickle down to the community level? Because sometimes we are actually able to use the data at the very local level, at the grassroots, while waiting for a national data. So again, we want national data to impact on policy, but how capable are the policymakers really in making use of the data, in translating the data into policies? Because we're talking about data generation. We are researchers, we do surveys, but the translation, I think, of this data also needs to be revisited. We need to reflect on how exactly all of these things that we're generating are useful to the people from whom we gathered the data. Thank you.
Thank you, Dr. Dina. And Dr. Alice?
I think Dr. Dina took the words out of my mouth there. I think for me, it's really in the translation where the key to this is. I don't think that there's a lack of data. And as we've heard from all of these presentations, there's more coming. There's lots of systems being set up. There's more being implemented. I think the biggest priority for all of us is how do we actually get that data back into the hands of the local decision makers, particularly. I think there's often big delays in the turnaround from research being done to it being fed back. And I think we can all play our part in terms of speeding that up and giving it back to the local decision makers.
Thank you, Dr. Alice. And thank you very much, everyone. That's all the time we have today. Thank you so much to our amazing panel for their insights, and to our audience for their active participation and questions to enrich the discussion. I think we all learned a lot from not just the data in terms of numbers and systems, but really going through translating to data use and the importance of things around the building a culture of evidence, the importance of building capacity, and having that enabling environment to make sure that the data can actually really be used to improve our health systems. On behalf of IDinsight and ACRI, I'd like to thank everyone, our speakers and participants, for joining us this afternoon. For our participants, please take the time to complete our post-event survey. As data is very important, it will give you the link in the chat box and the QR code on your screens, and you'll also receive an email. Please keep in touch with us by connecting with IDinsight and ACRI on Facebook, Twitter, and LinkedIn. And we hope today's discussion really opens a lot of doors and opportunities for better collaboration towards a rich culture of data use. I think it was also quite clear in the discussion today that there's a lot of opportunities for collaboration and complementarity. It's all of this is a responsibility of all of the actors in the country, not just of government, not just of national government. So thank you so much, everyone. And for our speakers and partners, I'd like to ask you to stay, to turn your cameras on for a quick photo opportunity. Great. I will count to 3 for us to take a photo. 1, 2, 3. Thank you so much, everyone. Thank you, Dr. Dairit, Dr. Gab, Dr. Dina, Dr. Olga, Dr. Alice, and our behind the scenes with IDinsight and ACRI. Thank you for organizing and for a successful event. And I hope this, even for among panelists as well, really, and the audience, I hope this can be a good opportunity for us to get to know each other a little better and follow up this discussion with more actionable next steps in really being able to enrich our data and making it useful for decisions across all levels. Thank you so much.
Thank you. Bye.
Thanks.
Bye.
Thank you. Bye.